For assessing joint range of motion or mobility, we can do it both actively and passively. And they're very different tests. And today I'll talk a little bit about how they're different and specifically what it's making me think diagnostically if there's a problem with either active range of motion or passive range of motion in one or more planes of a joint. So let me demonstrate with the shoulder just because it's easier to show. There are many planes of the shoulder when it comes to range of motion. One of them that I test is called horizontal adduction. Adduction or adduction is bringing the joint kind of closer to the body, and then abduction is away from the body. And in this plane of motion for the shoulder, we use the word horizontal, so parallel to the ground. So if we do it actively, that means that the patient is doing the work. And more precisely, that means the patient's muscles and tendons are doing the work. Those are the contractile tissues that have to work to move the joint itself. So active range of motion would be me asking the patient, bring your shoulder across your body or bring your arm across your body. And of course, at the end range, I'm having the patient apply some overpressure to assess that end range, passive range of motion. But just think that active range of motion means that you are doing it by yourself. So if the person cannot do this, or it's painful, that tells me something. If they can't do it, it can be a strength deficit. This is not a huge workload for the muscle to do it in standing, but if a patient cannot do the action, it makes me question if there's a lesion in the muscle or tendon, and therefore weakness is precluding them from doing the movement actively. There are many other reasons why someone may not be able to do a joint motion actively. You know, if there's a structural compromise, they may not be able to do it. If there's a non-musculoskeletal disorder, they may not be able to do it. Degenerative processes, etc. So it doesn't incriminate just the muscle. It can also be a joint derangement, making it mechanically hard for the patient to move that joint. But if there's a problem in terms of pain, meaning problem A would be they just can't do it, it doesn't even hurt, that would more likely incriminate weakness if it doesn't hurt at all. But if it's painful and they can't do it, so painful and weak, that gives us a different diagnostic idea with more of those on the table. But let's just say that the active range of motion is just painful in a certain range of the motion, but it's not weak. And we could corroborate that it's not weak if I apply pressure in terms of manual muscle testing. But if they bring their shoulder across and it hurts here, but then they can keep going, I'm much, much less inclined to think it's a muscle or tendon contractile issue. It could be, but I'm more likely to think it's a joint derangement. Something is not mechanically moving well in this area of the motion, but once they clear it, they can get by it. So active range of motion, as you can tell, does not tell us the whole story because it can be so many different problems that create a lack of active range of motion. And I'm not going to go into all the different stages today, but we can test muscles in different positions vis-a-vis gravity and assess how it's really functioning. So if a muscle can do a motion with gravity on its side, that's an easier task to ask a contractile unit to do. But if you're asking a muscle to work against gravity, that's harder. So there's different levels of using gravity that can help us get into the minutia of the strength of a muscle. And in outpatient orthopedics, that's not something I regularly do. It's something I would do more commonly when I did inpatient orthopedics or rehab, because those patients usually are more compromised in terms of their function and muscle strength. But for the average person walking into an outpatient clinic, they can typically move with gravity or without gravity. The problem usually becomes moving against gravity. So that's active range of motion in a quick nutshell. Passive range of motion, in contrast, is when the patient is not doing the work him or herself. So an external force is doing the work passively. And in this scenario, that means typically me. I'm taking the joint across the body, or they could do it to themselves at home. But the key is not that something else is helping. The key is that there's no muscle activation on the part of the patient. So they're completely passive. So I typically wouldn't really do it in standing because the patient's going to want to contract their muscles. It's just like common to want to do that, to hold the arm up. So if I wanted to really assess passive range of motion when it comes to shoulder horizontal adduction, I would have the patient lie on his or her back and I would passively take the shoulder into that position. So passively looks the same, but it's a completely non-responsive arm. It's not doing any work. And I usually have to tell the people, like, don't hold it, let it go, let me hold it, etc. And then I move the joint passively through the range of motion. And obviously if I'm starting from here to here, that's not all of the motion. That's from neutral to horizontal adduction. I could also go from full horizontal abduction through the entire range of motion. I pick the exact form and type of range of motion that I'm going to test for each person. For example, I might not even do passive range of motion. I probably won't do passive range of motion if active range of motion is completely normal. So every patient presentation has a slightly different physical exam in part 2 based on the verbal history and what I'm starting to think I need to test as baselines. So going back to passive range of motion, the patient's not using his or her muscles, I'm doing the motion. So diagnostically, this is really important to me because people get told a lot that they have tight muscles or weak muscles, and that's what's causing their problems. But when it comes to passive range of motion, we're taking muscle strength off the table. So if it's painful when I perform the motion passively, it can't be muscular or tendinous during the range of motion because they're not even working. It has to be something else. And that's where I start really questioning whether or not the problem at hand is a mechanical joint derangement. If passive range of motion is painful, obviously it could be, again, a fracture, a structural lesion, other processes that are less likely. But a mechanical problem, if the joint can't move and it's not because of the muscle or tendon, I'm thinking about is something mechanically not moving perfectly. And in Robin McKenzie's terminology, that would be a joint derangement. So say I take the patient passively and it's painless, and then at the end, they start to feel something. Well, then that's when the question becomes, where do you feel it? Because as you can tell, if I'm taking the patient here and they start to feel it at the end range, and you want to incriminate something being tight, well, where should that tightness be felt? Obviously where the tissues are being put on stretch. So if I ask them what they feel and they just feel like, oh, the normal stretch, normal strain, that's not pathology. But if they feel something like, oh, that hurts, the question becomes where. And if it feels like, oh, it's in the joint or it's in the front or it's pinchy on top, then I'm not ruling in tight tissue. I'm starting to more likely rule in a joint derangement of that joint. So passive range of motion gives me different ideas than active range of motion because it changes what we're testing. We're not asking the muscle tendinous unit to work. But say they can go all the way through, but it's really painful just through it with passive range of motion, and then I get all the way to the end and it clears. That's really incriminating the joint because, again, it couldn't be a muscle or tendon if it's painful in the mid-range and we're not asking the muscle and tendon to work. So something is causing it to be painful. And so if we've ruled out muscles and tendons, then of course we could rule in a lot of other things, but I'm not thinking ligamentous because it's not at end range. The ligament's not on stretch. It's not being asked to lengthen. So I'm not thinking muscle or tendon or ligament. And so those are common injuries that people are told that they have that I think they're overdiagnosed incorrectly. So what else could it be? Yes, it could be something structural in terms of a degenerative process or structural in terms of, a meniscal tear or something in a knee. But I'm really starting to think something is mechanically wrong in the joint. And when I keep using that term, what I mean is a physiological problem, not a structural problem. I mean, something's just not moving well, kind of like when you shake the kitchen drawer to get it to move well again. I'm starting to consider, do we just need to mechanically get that joint moving well again? So like the kitchen drawer can now open, fluidly, that joint now moves fluidly. And how do I figure that out after I take active and passive range of motion in different planes for different joints? I use repeated movement testing, which is testing by moving the joint in a specific direction and assessing the effect on the active and or passive range of motion. If we do, for example, movement of the shoulder into horizontal abduction to end range, and previously adduction was painful passively in mid-range, and that starts to clear, it's not gone, but it's less painful, then that would make me start to think, well, maybe this is a joint derangement, mechanically obstructed, and therefore we need to find a direction that gets it on track again, and horizontal abduction done repeatedly might be the answer. So active and passive tell me different things. I'm typically not testing passive range of motion for the entire range of motion if the active is full and painless, although I will apply overpressure at the end just to make sure that we're getting to the full end range and assessing what happens there. But we can use active and passive range of motion to kind of debunk these ideas that all these problems are muscles or tendons. There's a difference between a restricted joint in terms of mobility and an obstructed joint in terms of mobility. And when I was in school, I learned a ton about joints being restricted, and what is restricting them from their full range of motion? Usually muscle tightness. It could be other things, but ligaments don't usually restrict joints, right? If ligaments are injured, they get stretched, they get longer, so the ligamentous tests show laxity. So if I was taught that joints are tight because muscles are tight, that's a restriction. And again, patients will feel the restriction at the end of the motion, either actively or passively, but they will not feel it in just a vague space. They will feel it where that tight tissue is being asked to lengthen and it can't. In contrast to a joint losing mobility because of tissue restriction, we have joints losing mobility because of obstruction. And that's the term that I didn't learn until several years into my career. And many things can cause obstructions, right? A fracture and a piece of bone sitting in the middle of the joint cavity can cause an obstruction to movement. So structural problems that have had, debris floating around the joint can cause an obstructed joint. Or swelling, inflammation can cause joint obstruction. And people can kind of think of that if they have an injury and there's a lot of swelling, they don't have full range of motion. And it's not because necessarily a tissue is tight. It's because there's space occupation in the joint itself with water, with fluid. And so you can't move mechanically well. But what Robin McKenzie put forward is the idea that a joint is obstructed in its range of motion because of a mechanical problem, meaning something is causing that joint not to move appropriately. And we have different ideas about what that could be. I think in the spine, we can implicate the disc in many cases. When it comes to the extremity joints, I'm curious, is it a fat pad? Is it a piece of small cartilage, a piece of small debris in the area? We don't know. But what we can tell is that we can use repeated movement testing and see it with our own eyes, cause and effect. If we move the joint in this direction, does it change the obstruction in that mobility? So obstruction would be when the joint just doesn't move, either actively or passively, or it's obstructed in that the patient can do it, but it's painful during it, right? Either in the whole range of motion or just a piece of it. So I really want people to start to understand that that's a phenomenon that occurs a lot, is obstruction of mobility, not just restriction of mobility. Because I think most people are treating restriction, meaning I can't touch my toes, ergo my low back muscles or my hamstrings are tight. They are restricted, so the cure is to stretch those muscles. And that's not what I find in the clinic. Because let's say a person comes in and thinks that they can't touch their toes because their hamstrings and or low back extensors are tight. And then they're lacking 50% of low back extension. Well, that would kind of throw into question this theory of loss of low back mobility because of tight hamstrings or low back extensors, because they would not stop someone from extending. So just that piece of information alone would make me start to think you're not missing toe touching because of restriction, you're missing toe touching because of obstruction. So again, question these ideas of restriction because of tightness of tissues, including muscles, tendons, fascia, or even scar tissue, and start to think, well, maybe my joint's not moving well because it's obstructed. And if that's the case, repeated movement testing, you can buy the books by Robin McKenzie and assess on your own, or find a clinician who's really high level at using repeated movement testing. Use that to see if there's a key to unlock your mobility, so to speak. A movement repeatedly in a specific direction that clears that obstruction and allows the joint to move well in all planes without pain.